I'm here today to talk to you about a recent analysis about the questionable validity of the catheter-associated urinary tract infection metric for value-based purchasing. We're going to be talking a lot about CAUTIS, so I thought it would be good to start off with what exactly is a CAUTI. CAUTI is a catheter-associated urinary tract infection. It's a UTI associated with an indwelling catheter that provides a very easy means of access for microorganisms to set up an infection anywhere along the urinary tract. CAUTIs are projected to occur in 290,000 U.S. hospital patients annually and cost $290 million. The key prevention mechanisms for CAUTIs focus around sterile catheter insertion, proper catheter maintenance, and most importantly, decreasing catheter usage. So here we see a list from the CDC of appropriate uses for the indwelling catheter. Like I said, I'm a critical care nurse, so a common indication is for an accurate measurement of the urinary output in critically ill patients in order to guide treatment and ensure adequate perfusion of the kidneys. They're also used for acute urinary retention, perioperative and intraoperative monitoring of urinary output, assisting in healing of open sacral or perineal wounds to ensure a clean environment, and patients requiring prolonged immobilization, either due to a spinal injury or perhaps multiple traumatic injuries. Lastly, they can be used to improve comfort for end-of-life care if warranted. Here is a table from AHRQ demonstrating the relative risk factors for acquiring a CAUTI. And as we can see at the top, the highest risk factor is prolonged catheterization, which is greater than 6 days. So really what this table is showing us that the most important factor to decrease the CAUTI rate is to remove unnecessary Foley catheters and minimize the time that they are catheterized. Here we have a list of alternatives to less invasive measures of monitoring urinary output. First, we have the external catheter for men. This is commonly referred to as the condom catheter because that's frankly what it looks like. It's a much less invasive means of measuring urinary output. The caveat is that sometimes they don't fit or they don't stay on. There's also intermittent catheterization, which uses a bladder scanner to determine the fullness of the bladder and to see if it needs to be in and out cast. This is better than an indwelling Foley catheter because you're not maintaining a catheter in the patient. It's just an intermittent, every few hours sort of thing. Third, we have scheduled toileting, which is having the nurse and nursing assistant get the patient up to a bedside commode. This is probably the best alternative if it will work. The problem is that some of our patients take 2 to 3 nurses or nursing care assistants in order to get the patient to the toilet. So in order to do this, it really hinges on having adequate staffing ratios. Fourth and sort of our last alternative to Foley's is the suprapubic catheter. So how we measure CAUTI rates is very important for value-based purchasing. Hospitals now are penalized 1% of their entire Medicare fee reimbursement if they are performing in the lowest quartile for hospital-acquired condition reduction. This penalty is levied in an all or none fashion and totals $373 million across 721 institutions. The importance of the CAUTI metric is that 1/3 of the hospital-acquired condition penalty is based off of this metric. So CAUTIs have gotten a lot of attention recently. I wanted to include some of the interventions that the hospital I work at has implemented, which is pretty much standard across the country. First of all, we are focusing on improving catheter maintenance, which is primarily by Castile soap, wipes, and we trialed a new TheraWorks spray. The hopes of this is to decrease the biofilm and in that sense decrease the CAUTI rate. The second area is the Foley Care Bundle, which is really focused around improving nursing education so that we're not inadvertently causing CAUTIs when we were not intending to. So the first is ensuring that the Foley bag never touches the floor, and the tubing remains kink-free in order to allow for free flow. The Foley securement devices ensure that the Foley is attached to the upper leg in order to prevent inadvertent in and out movement of the catheter around the urethra, which would inadvertently introduce microorganisms. We've also moved towards maintaining a closed system. So it used to be that if a Foley catheter came in from an outside hospital that did not involve a urometer, we would simply change out the bag, which is far away from the patient, but it did break the closed system. So we now no longer do that. If the patient requires a change in the urometer, the entire system is changed out. Lastly, we have moved towards documenting the reason for Foley necessity every shift. This is just to kind of remind the nurse, you know, and questioning, is this really necessary? Is this something that we could discontinue? We have also moved towards implementing nurse-driven catheter removal protocols. So these are algorithms that allow us to proactively remove the catheter without an MD order. Again, just trying to get those unnecessary Foleys out. Also started doing CAUTI huddles to identify trends and gaps, and have included catheter necessity on our daily rounds. Ultimately, the most important intervention, again, to reiterate, is to reduce the CAUTI rate, is to remove the unnecessary Foley catheters. However, this does hinge on having adequate staffing ratios. So we turn our attention to the CDC's analysis of the CAUTI rate between 2009 to 2013. We have two sets of data from the CDC. The first one on the top of the screen was downloaded from data.medicare.gov. This data increase in the CAUTI rate between the years of 2009 to 2013. For our second data set, comes from the CDC annual report on hospital-acquired infections. This data set includes more hospitals because it includes all of the data from all of the hospitals that report to the NHSN, and includes patients throughout the hospital, not simply those in the intensive care unit. If we look at this data, we see now a 6% increase in the CAUTI rate. And it just, you know, we started thinking, how is it possible that despite this attention, we are increasing our CAUTI rate and decreasing our quality of care? So we looked a little bit closer at the CDC Metric. Some important things to consider about how we are analyzing our CAUTI rate. First and foremost, this data is all self-reported from the hospital and is not necessarily independently verified. This is our current metric, and the way it is calculated is you take the number of urinary infections and divide it by the number of catheter days. This is then converted into a standardized infection ratio by dividing that number by 1,000, which simply makes the numbers easier to work with. The important thing here is that we're really measuring CAUTI rates based off of the number of catheter days. So we started thinking, is this a really accurate way to measure our performance? We looked at another metric for CAUTIS, which is from the Agency for Healthcare Research and Quality. This data is obtained directly from medical records and is not self-reported. The way that it is calculated is it takes, again, the number of urinary infections and divides it by hospital discharges, which is, again, then divided by 1,000. So the AHRQ data was derived from an analysis of 18,000 to 33,000 randomly selected medical records per year. So really the difference between these two metrics is the CDC is looking at number of catheter days, while the AHRQ is looking at hospital discharges. Let's see what the AHRQ shows us. If we use this metric, we see that, again, over the same time frame, we now have a 28.2% decrease in the CAUTI rate. This is a statistically significant value with a p-value less than 0.011. So again, to reiterate, with the CDC metric, our current metric, it has shown an increase in the CAUTI rate between 3 to 6% between the years of 2009 to 2013. If we look over the same time frame, With the AHRQ, it shows a significant decrease in the CAUTI rate of 28.2%. So we started thinking a little bit more deeply about this metric, and some of our concerns relating to the CDC metric is that it does not account for catheter removal. In this day and age, facilities may be cutting staffing in order to augment income. 50 to 70% of a hospital's operating budget is for staffing, and nurse staffing comprises greater than 50% of their staffing expenses. So by not including catheter removal in the CDC metric, hospitals are not incentivized to provide adequate staffing ratios. Secondly, data is self-reported from hospitals and not independently verified. The CDC reports that only 20 to 50% of states check the CDC NHSN CAUTI data for quality and completeness. I kind of just wanted to give you a little scenario about how the CAUTI rate could be inadvertently exaggerated. So assume that we were functioning in the ideal hospital system where every unnecessary Foley catheter was removed. In our situation, Foley catheters would be left in the sickest patients, primarily ICU patients, who are already at an increased risk of obtaining a urinary tract infection. So we have now decreased the number of CAUTI days, which is the denominator for the CDC metric. In doing this, we may inadvertently increase the CAUTI rate by decreasing the denominator. That's really what our concern is here. Some of the limitations of this analysis: the AHRQ metric is not risk adjusted and may not have the same validity in making comparisons between facilities that care for different levels of acuity of patients. Secondly, the data sets were comparing two different patient populations. The AHRQ metric analyzed a subset of the population with the diagnoses of myocardial infarction, heart failure, pneumonia, and major surgical patients, while the CDC metric looked at all reported catheters. Our analysis does not claim that the AHRQ metric is flawless and should be immediately adopted. Instead, our primary intention is really to call attention to the fact that there's this large discrepancy between the two metrics, and to advocate for a more appropriate metric that will properly incentivize hospitals to adequately staff their units and enable a culture of patient safety. In order to do this, we recommend that the CAUTI metric should incorporate both catheter usage and catheter care. APIC indicates that catheter usage is more important than catheter care, and this clearly makes sense. If you decrease catheter usage and remove Foley catheters, you cannot have a catheter-associated urinary tract infection. So catheter usage should be emphasized. And we are certainly concerned that the current metric fails to accurately differentiate between good and poor performers, which was our goal from the beginning. The CDC Guidelines state that it is inappropriate to use urinary catheters as a substitute for nursing care of the patient or resident with incontinence. Inadequate staffing forces nurses to prioritize care based on the most immediate needs of their patients. Patients with life-threatening developments will always be prioritized over proactive efforts to decrease CAUTI rates. As nurses these days are expected to take care of an increasing number of patients and patients with increasingly complex disease processes, inadequate staffing leaves providers feeling overwhelmed and unable to provide optimal care, as we can see from this cartoon, which is pretty accurate. Adequate staffing ratios are required to remove unnecessary Foley catheters in incontinent patients to allow for frequently changing wet linens and briefs. If these linens and briefs are not frequently changed, they will very quickly develop moisture-associated dermatitis and skin breakdown, which can also not be considered quality care. Our current metric may inadvertently penalize hospitals for removing unnecessary Foley catheters. The CAUTI metric should reward hospitals that promote adequate staffing and foster a culture of patient safety. And here we just have some references. I'm happy to answer any questions if anybody has any.